Disclaimer. The views and opinions expressed in this video are solely my own and do not represent those of any healthcare organization, employer, professional association, or regulatory body. The information provided is based on sources cited at the end of this presentation and reflects my understanding at the time of recording. This content is for general informational and educational purposes only and should not be interpreted as medical advice, clinical guidance, or an official position on any healthcare matter. It is not a substitute for professional consultation, diagnosis, or treatment. If you are employed in a healthcare setting or are a licensed healthcare professional, please consult your organization's compliance department, applicable licensing boards, or other authoritative bodies for official guidance and clarification on the topics discussed. Hi, everyone. My name is April Fain. I'm an AAPC certified professional coder, auditor, outpatient documentation expert, and an AAPC approved instructor. And today we're going to discuss how to master assigning accurate ICD-10-CM codes for strokes. We will be learning the anatomy of a stroke, the different types, the sequelae or late effects of strokes, and some common coding challenges. I'm excited to share this with you today, so let's get started. The first step in assigning codes is to be able to answer the question, what is a stroke? Merck Manual Professional Version states that strokes are a heterogeneous group of disorders involving sudden focal interruption of cerebral blood flow that causes a neurologic deficit. A more straightforward way to answer the question is to simply say that strokes are made up of different types of disruption of blood flow to the brain that causes a loss of function or some type of impairment. Now we're going to explore strokes that occur within the brain. And here's an example of what the brain looks like. Let's break this down further and explore the different parts. As you can see from the illustration here, the brain consists of three main components, which are the brainstem in the lower extension of the brain at the base that is connected to the spinal cord, the cerebellum located at the back of the brain, which is above the brainstem but below the cerebrum. And the cerebrum forms the major portion of the brain, and it is divided into two hemispheres, the right and the left. The brain is divided into four lobes, each responsible for different functions that affect the body. The frontal lobe controls reasoning, decision-making, problem-solving, and voluntary movements, playing a key role in personality and speech. The parietal lobe processes sensory information like touch, temperature, and pain, helping with spatial awareness and coordination. The temporal lobe is essential for hearing, memory, and language comprehension, influencing how we process sounds and emotions. Lastly, the occipital lobe is primarily responsible for vision, interpreting visual information from the eyes to help recognize objects, colors, and movement. Together, these lobes work to regulate thought, movement, sensation, and perception. It's vitally important to understand this information as you will refer to it often when assigning codes for specific strokes that occur in one or more parts of the brain, including the lobes. This is a great example illustrating how the brainstem is connected to the spinal cord. The brain and spinal cord make up the central nervous system. And it's important to understand how the brain and spinal cord interact because strokes can also occur in the spinal cord as well, known as a spinal stroke or spinal cord infarction. An infarction simply means a condition where tissue dies due to a lack of blood supply. Now we're going to talk about the different types of strokes, such as ischemic, hemorrhagic, and transient. It's important to understand these details as you will refer to the specific type of stroke when assigning ICD-10 codes. An ischemic stroke is described by Merck Manual Professional Version as sudden neurologic deficits that result from focal cerebral ischemia associated with permanent brain infarction. So, we're going to break that down just a bit to describe it in a more straightforward manner. Neurologic deficit simply means that the nervous system is not functioning correctly and could cause the patient to experience certain symptoms like weakness or paralysis, numbness or tingling, problems with coordination or balance, memory loss or confusion, speech difficulties like garbled speech or slurred speech, vision disturbances such as vision loss or double vision, headaches, and even seizures. Focal cerebral ischemia means that blood flow to a specific area of the brain is reduced or blocked, which leads to death of brain tissue, also called cerebral infarction or ischemic stroke. Be sure to read the documentation carefully when assigning an ICD 10 code for strokes. There are specific codes that occur in various arteries, such as the anterior, middle, and posterior cerebral arteries, as well as the vertebral and basilar arteries, and the particular mechanism that caused the stroke, whether it was because of an embolism, occlusion, stenosis, or thrombosis. We will cover each of these in the following slides. Common causes of an ischemic stroke is an occlusion or blockage of a blood vessel which prevents blood from reaching the brain tissue. And without oxygen rich blood, brain cells begin to die. A cerebral embolism occurs when a blood clot or other debris, called an embolus, forms in another part of the body, often the heart or large arteries, and travels through the bloodstream to the brain, where it blocks a cerebral artery. This sudden blockage cuts off oxygen supply to brain tissue, potentially causing a stroke. Cerebral stenosis refers to the narrowing of the arteries that supply blood to the brain, usually due to atherosclerosis, where plaque builds up inside the artery walls. This narrowing restricts blood flow, increasing the risk of ischemic stroke if a clot forms or if blood supply becomes critically low. The most commonly affected arteries include the carotid arteries, which are in the neck, and the intracranial arteries within the brain. Cerebral thrombosis occurs when a blood clot or a thrombus forms within one of the brain's arteries, blocking blood flow and potentially leading to an ischemic stroke. The main difference between a cerebral thrombosis and a cerebral embolism is that a blood clot or a thrombus forms directly within an artery supplying blood to the brain. An embolism happens when a clot or debris called an embolus forms elsewhere in the body, such as the heart or carotid arteries, and travels through the bloodstream to block a cerebral artery. Now that we've learned about ischemic strokes occurring in the brain, let's talk about the next type of stroke, the hemorrhagic stroke. A hemorrhagic stroke occurs when a weakened blood vessel in the brain ruptures, causing bleeding, also known as hemorrhage, into the surrounding brain tissue. This bleeding damages brain cells by increasing pressure and reducing oxygen supply. Hemorrhagic strokes account for about 15% of all strokes, but tend to be more severe than an ischemic stroke. The types of hemorrhagic stroke include intracerebral hemorrhage, which is bleeding directly into the brain tissue, often caused by hypertension or high blood pressure, trauma, or blood vessel abnormalities. Subarachnoid hemorrhage is bleeding into the space between the brain and the thin membranes covering it, usually due to a ruptured aneurysm or arteriovenous malformation, also known as AVM. The first type of cerebral hemorrhage is the intracerebral hemorrhage. This simply means that there is bleeding from a blood vessel in the brain parenchyma, or the functional tissue of the brain that is made up of two kinds of brain cells, neurons and glial cells. A subarachnoid hemorrhage is bleeding in the space between the brain and the tissues that cover the brain, and the space is known as the subarachnoid space. A subarachnoid hemorrhage is a type of stroke. It is actually a medical emergency that needs treatment right away. A transient ischemic attack, also known as TIA or a mini stroke, is a focal brain ischemia or lack of blood flow that causes sudden transient neurologic deficits. The word transient means that the lack of blood flow is temporary. It lasts for only a short period of time, usually less than an hour, and it completely resolves without any permanent damage or lasting effects. Now we're going to talk about the sequelae of strokes, or the late effects. And the word sequelae simply means that the late effects or complications are typically long-term, and these occur as a result of a stroke. Sequelae is actually the plural for the word sequela. There are many and varied types of complications that can result from a stroke. The late effects of strokes can result differently depending on what hemisphere the stroke took place. For example, if a stroke occurred in the left part of the brain, the right side of the body will be affected. This can cause paralysis on the right side, also called hemiplegia. There can also be sensory deficits on the right side of the body, like numbness and tingling. A patient can experience speech and language problems like aphasia, which affects the ability to understand or use language. Another speech problem called dysarthria is where you have difficulty speaking because the muscles you use for speech are weak. A patient could also experience problems with thinking, memory, problem solving, and could exhibit behavioral disturbances. Now let's look at some documentation of what to look for when assigning ICD-10 codes for the sequelae or late effects of a stroke. The assessment and plan shows that the patient suffered a stroke 14 months ago with residual right-sided hemiplegia and expressive aphasia. The provider also mentions that the patient is now wheelchair dependent since the stroke. So for this scenario, we would assign I-69.351 for hemiplegia following cerebral infarction affecting the right dominant side, and I-69.320, which is for aphasia following cerebral infarction. And we can also assign Z99.3, which is for dependence on wheelchair. Now that we've assigned some ICD-10-CM codes for this patient encounter, let's go over some guidelines to explain why I chose these particular codes. The ICD-10-CM guidelines gives a description of what sequelae or late effects are and provides an explanation for how to code this type of diagnosis. Now, we talked about this before, but let's go over this again. It is very important that you know there are guidelines that give specific information that must be followed in order to assign the most accurate and specific code to reflect the documentation. The sequelae, or sequela, is a residual effect or a condition that is produced after the acute phase of an illness or injury has terminated. There is no time limit when a sequela code can be used. The residual may be apparent early on, such as in cerebral infarction, or it can even occur months or years later, but those are usually for other types of injuries. Coding sequela generally requires assigning two codes. You will assign the condition or the nature of the sequela first, and then the sequela is sequenced second. The code for the acute phase of an illness or injury that led to the sequela is never used with the code for the late effect. And what this means is simply you would not assign an acute ischemic stroke I63.9 with the sequelae of a stroke like aphasia. So you would instead locate the code in your ICD-10 book or other computer-assisted coding program for aphasia following a cerebral infarction as shown in the example here. Okay, so now let's talk about the ICD-10 code for the residual right-sided hemiplegia. The guideline states that if an affected area is not specified in the documentation, then you would select a code as follows. For ambidextrous patients, the default is dominant. If the left side is affected, the default is non-dominant. And if the right side is affected, the default is dominant, like our example here. The provider did not specify if the patient is right or left hand dominant, so therefore we chose the code to specify that his stroke produced a right-sided hemiplegia. According to the guidelines, we're going to use the right side as the dominant side for this patient. Okay. So let's summarize this particular coding scenario in a very concise manner. This patient had an ischemic stroke 14 months ago. That means that the stroke is not acute but chronic. They have suffered some complications from the stroke, namely right-sided hemiplegia or paralysis and expressive aphasia, which means they've lost the ability to understand or produce speech. The paralysis affected their ability to walk, and now they're dependent on a wheelchair for mobility. And since we know that the stroke was in the past and has caused lasting effects, we're going to look up the term sequelae when assigning an ICD-10 code. After locating the term sequelae, we will look for the term infarction. And then we're going to find the particular sequela that was documented and assign those codes to the encounter. Remember, we do not assign an acute stroke code with a sequela code. The patient had this stroke 14 months ago. Make sure and read any section or code notes for each diagnosis code and follow the coding conventions in the ICD-10-CM guidelines. Now, you don't have to memorize the guidelines. You just have to know where to find the information. And the more familiar you are with the guidelines, the easier it gets to assign the most specific and accurate codes. Before we move on to our final section of the presentation, let's recap what a hemorrhagic stroke is, and we're going to learn how to assign codes for the sequelae of a hemorrhagic stroke. A hemorrhagic stroke occurs when a weakened blood vessel in the brain ruptures, causing bleeding or hemorrhage into the surrounding brain tissue. This bleeding damages brain cells by increasing pressure and reducing oxygen supply. Assigning ICD-10-CM codes for the sequelae of a cerebral hemorrhage is very similar to ischemic stroke coding. Simply locate the term sequelae in your code books or other coding assistant software illustrated here. Next, you're going to look for the term hemorrhage, followed by the type of hemorrhage. You will choose either intracerebral, intracranial, or subarachnoid based on the documentation. Also note that these specific types of cerebral hemorrhages or strokes are non-traumatic. The word non-traumatic means that the cerebral hemorrhage was caused by the rupture of small blood vessels in the brain. This is often caused by hypertension or a condition called cerebral amyloid angiopathy, which is when abnormal proteins build up in the blood vessels of the brain, which damages it and causes bleeding inside the brain. This condition can be caused from inheriting certain genetic mutations, having Alzheimer's disease, hypertension, among others. Now let's take a look at how to assign an ICD-10 code for the current patient illustrated here. This is a 52-year-old patient found to have a subarachnoid hemorrhage, which was discovered on MRI during their inpatient stay in October 2024. The patient presents today with severe gait ataxia secondary to the stroke, which has been present since their initial presentation last October. Patient here today for follow-up and prescription management of nimodipine. So the correct diagnosis code for this encounter is I69.093 for ataxia following a non-traumatic subarachnoid hemorrhage. When determining what code to assign, I referred to my coding book and found the term sequelae, followed by hemorrhage, then subarachnoid, and finally ataxia. We're going to look at some common coding scenarios that can be challenging at first until you become familiar with the coding conventions and section notes in the ICD-10-CM guidelines. It's also very important to understand the anatomy of the brain and the terminology involved in assigning the most specific and accurate codes. Assigning the codes with the highest specificity not only affects billing and reimbursement, but it also ensures proper patient care through maintaining the integrity of the patient record and provides valuable data for research and public health efforts. One of the most common challenges for assigning ICD-10-CM codes is sometimes related to provider documentation. Many times, an acute stroke might be documented as simply acute stroke without any further specificity. ICD-10-CM requires specific codes for different types of strokes, whether they're ischemic, hemorrhagic, or transient, and their location, such as specific arteries or brain regions. Lack of clarity in documentation about the stroke type, location, or cause can lead to miscoding. You may need to carefully examine the documentation, looking for specific areas where the infarction occurred, and then assign those codes that reflects the documentation. However, remember, we as coders do not interpret test results, so we have to be careful whether we can assign an unspecified code or one that is more specific, such as cerebral infarction due to stenosis of right middle cerebral artery. Another challenge is finding that the provider did not link a chronic disease, such as hypertension, with a stroke. If hypertension is documented in the patient's note, we can assign the code based on ICD-10 guidelines. This patient has a history of atrial fibrillation and is taking Eliquis to manage this condition. He also has a history of TIAs and is taking Plavix. The documentation also mentions that he has hypertension and takes amlodipine. He is a former smoker and has a pacemaker implant. The provider addresses the hemorrhagic stroke under the assessment and plan, however, does not link the hypertension or the smoking status. Okay, for this scenario, I'm going to look up the code for the non-traumatic right frontal cerebral hemorrhage. I look for the main term hemorrhage and then intracranial / intracerebral. And for the purposes of this documentation and this presentation, I'm going to assume this hemorrhage is non-traumatic. Once I select intracerebral, non-traumatic, I find hemisphere and then cortical, and from there I find my code, which is I61.1. non-traumatic intracerebral hemorrhage in hemisphere cortical. Now this means that there is bleeding into one side of the brain. Intracerebral hemorrhages are classified by the site involved, such as the cerebrum, which consists of 2 hemispheres and 4 lobes, as we mentioned in earlier slides of this presentation. Those 4 lobes are frontal, parietal, temporal, and occipital. The documentation specifies right frontal lobe. The word right refers to the particular hemisphere or side of the brain where the bleeding occurred. The documentation tells us that the bleeding occurred in the frontal lobe. In the code book, we have 2 options to choose for this type of hemorrhage, the cortical or the subcortical. So let's take a quick look at the structure of the brain. The word cortical is an adjective for the word cortex. The word cortex simply means the outer or superficial part of an organ or body structure, such as the cerebral cortex. As I mentioned earlier in the presentation, the cerebrum makes up the major portion of the brain. The cerebral cortex is the outermost layer of the brain, or the superficial part, and consists of 6 layers of nerve cells. Again, the cortex is divided into 4 lobes, so the word cortical refers to the cortex of the cerebrum, or the outermost layer. Therefore, I chose the code I61.1 for non-traumatic intracerebral hemorrhage in the right frontal lobe. There isn't a more specific code for the right hemisphere where the stroke occurred, so the only option we have to choose from is I61.1. All right, now that we've reviewed the anatomy of the cerebrum and have a better understanding of how to apply ICD-10-CM codes based on the documentation, let's continue learning how to apply coding conventions from the ICD-10-CM guidelines that directs us to use additional code when assigning codes for this particular type of stroke, as illustrated here. Certain conditions have both an underlying etiology and multiple body system manifestations due to an underlying etiology. And for such conditions, the ICD-10-CM has a coding convention that requires the underlying condition be sequenced first, if applicable, followed by the manifestation. So whenever a combination exists, there is a use additional code note at the etiology code and a code first note at the manifestation code. Now, we need to know this information so that when we are looking up our code for the hemorrhage, or if it's an ischemic stroke, whichever type of stroke we're looking for, we need to also be looking at the section notes to see if there are any coding conventions such as use additional code. And we have one for this particular hemorrhage. As you can see here, the section notes show that if we are using this code, we need to use additional codes to identify the presence of alcohol abuse and dependence, exposure to environmental tobacco smoke, history of tobacco dependence, hypertension, occupational exposure to environmental tobacco smoke, tobacco dependence, and tobacco use. We would not use a code for traumatic intracranial hemorrhage, as it states there with the excludes one convention. So since our documentation shows that the patient has a history of smoking and they also have hypertension, we are going to follow these section notes, and we are also going to apply and assign the codes I-10 for hypertension, and we're going to be using the Z87.891, which is history of tobacco dependence. Now, going back to the coding convention, let's look at the next one. It says with. The word with or in should be interpreted to mean associated with or due to when it appears in a code title, the alphabetic index, either under a main term or subterm, or an instructional note in the tabular list. This is important to read and understand, as we will apply these in a case in a later slide. So let's talk about this for just a moment. The classification presumes a causal relationship between two conditions linked by these terms in the alphabetic index or the tabular list. These conditions should be coded as related even in the absence of provider documentation explicitly linking them, unless the documentation clearly states the conditions are unrelated, or when another guideline exists that specifically requires a documented linkage between the two conditions. So we're going to talk about this, as I mentioned before, at a later slide, but keep that in mind when we start looking at a case where a patient has hypertension, heart failure, chronic kidney disease, and they also have an acute stroke. Okay, so let's move forward, and we're going to talk about this just a bit more, and then we're going to move on to our second case. Looking in the code book, we also have one more coding convention to follow when applying a code for this particular scenario, for the non-traumatic intracerebral hemorrhage in the right frontal lobe. There is another convention that says use additional code if known to indicate National Institutes of Health Stroke Scale, or the NIHSS score. Now, this is one of those additional codes that you would add if you know the information, meaning if it's been documented or not. The National Institutes of Health Stroke Scale is used to evaluate neurologic outcome and degree of recovery for patients with strokes. It was designed by a group of stroke research neurologists to document the baseline severity of neurologic deficits in acute stroke patients. The scores and the corresponding codes range from 0 to 42, with 42 being the highest severity stroke. So you would code first the type of cerebral infarction, followed by the National Institutes of Health Stroke Scale score. And then codes from this subcategory may be assigned based on medical record documentation from clinicians who are not the patient's provider. Okay, so now let's jump right into case 3 and determine if there are any ICD-10-CM coding guidelines that pertain to this scenario. This is an 86-year-old patient presenting with symptoms of dysarthria and right-sided weakness. She states that she woke up feeling off. She tried to get up out of bed and stumbled. She called out to family members and they stated that she had garbled speech. So they brought her to the hospital and neuro has been consulted to evaluate the patient. The provider noted that the patient has a past medical history of hypertension, hyperlipidemia, diabetes type 2, chronic kidney disease stage 3B, and a history of falling. A stroke score of 3 has been documented. She also has some past surgical history, including a pacemaker. She is a former smoker. And the primary diagnosis under the assessment and plan illustrates that she has had an acute ischemic stroke, and it was caused by stenosis of the left middle cerebral artery, which was seen on MRI of the brain. The provider also lists her other chronic conditions of hypertension, hyperlipidemia, CKD3B, and diabetes type 2 with the treatment plans which are noted below. So the first thing we're going to do is determine if there are any guidelines that we need to follow. But let's start with that stroke diagnosis code first and see where it takes us. Before we begin looking up the ICD-10-CM code for this type of stroke, let's take a minute and look at an illustration of the cerebral arteries in the brain. I found this great illustration from Merck Manual Professional Version with a link to the source located at the bottom of the screen so that you may look it up as well. We know from reviewing the documentation that the patient suffered a stroke in the left middle cerebral artery due to stenosis or narrowing of the vessel. The brain requires a steady flow of oxygen-rich blood and nutrients that is essential for optimal brain function. The middle cerebral artery supplies blood to the frontal, parietal, and temporal lobes and the subcortical or deep brain areas of the basal ganglia and the internal capsule. The patient's symptoms of dysarthria and right-sided weakness were caused by the lack of blood flow due to the narrowing of an artery. Atherosclerosis is the most frequent cause of this type of stroke. And atherosclerosis involves the buildup of plaque or fatty deposits on the artery walls. Hypertension and hyperlipidemia probably contributed to her stroke. I think that having an illustration to look at can be quite helpful when determining what ICD-10-CM code to assign. So I often refer to the images of brain anatomy, including the arteries, and it's been quite beneficial. Okay, so we've learned a little about the cerebral arteries, their function, and where they're located. Now we're going to learn how to look up the code for stenosis of left middle cerebral artery infarction And I'm using Encoder Pro, but you can also follow along in your ICD-10-CM codebook. So when I log into Encoder Pro, it takes me to this page here. I'm just going to make sure and click on this little button here. It says index only search. I'm going to make sure that it is set to ICD-10-CM. And then I'm going to type in the term infarct. It's going to take me here, and I'm going to scroll down to cerebral. I'm not going to pay attention to this word in these terms here, occlusion and artery cerebral or pre-cerebral, because I can scroll right down and see the word due to. And if you look in your code book, you're going to have that option as well. So you can go on down, and it's a stenosis, and it's a cerebral artery. Now, we've not gone over pre-cerebral arteries or small arteries. I'm going to go over those in future slides. So I know it's cerebral. I'm going to click on this I-63 category. I-63.5. So this one here has been highlighted in this yellow color and lets me know where I'm at. I'm going to look for the word left middle cerebral artery, which is here. So it's I-63.512, cerebral infarction due to unspecified occlusion or stenosis of the left middle cerebral artery. Now, there's some great information here that's provided to you about describing this condition a little bit more. So if you're not familiar with stroke coding, this is some great information here if you have access to Encoder Pro. Also, I want to point out that if you scroll on down, you're going to see the section notes are here, and it tells us to use additional codes to identify the presence of these particular conditions as well, like we talked about in earlier slides. Okay, now one more thing I want to point out to you is this excludes one. This means that you would never code this SO6 traumatic intracranial hemorrhage code. You would never code that with I-63.512. That's what excludes one means. It means those two codes can never be coded together. If you see a convention that says excludes two, that means that they can be coded together or under certain circumstances. They're usually not, but they can. But excludes one means that you would never code these together. Okay, so I'm going to go back to my code now, I-63.512. That is the code I'm going to apply to my encounter. And we're going to move further, and we're going to look back at that encounter again and see what other codes we need to pick up. After assigning the ICD-10-CM code I-63.512, I continue looking for additional codes to apply to this patient's encounter. I see that the patient has hypertension, chronic kidney disease, and diabetes type 2. So I will check the coding guidelines to see if there are any instructions for coding conditions that might have a causal relationship. Okay, so now let's look to see if there are any ICD-10-CM coding guidelines that are specific to this particular patient encounter before we start assigning codes. So I'm going to go down here. I'm on Encoder Pro. You can also follow along in your ICD-10-CM codebook. So I'm going to go click on this hyperlink here. Make this a little bigger. And I'm going to, on my keyboard, I'm going to press down Control and F, brings up my search feature. And I've already got this term loaded up in here on causal, so let's see what it says. All right. We talked about this in earlier slides, but let's just go over it one more time. So the word with or in should be interpreted to mean associated with or due to when it appears in a code title. Now, this is what I specifically want to talk about here, is this. These conditions should be coded as related even in the absence of provider documentation explicitly linking them, unless the documentation clearly states the conditions are unrelated or when another guideline exists that specifically requires a documented linkage between the two conditions. Okay. So let's go ahead and let's start coding this particular scenario and see if any of those pop up as coding conventions for us when we pull up each individual diagnosis. So the first thing I'm going to do is make sure that I have clicked index only search and it's on ICD-10-CM. And I'm going to type in the term hypertension. You don't even have to type in the entire term, just even part of it. It will pull something up for you. So as you can see right underneath, it's got the word with. Means there may be a causal relationship with kidney disease. So let's scroll on down and look for the term kidney. Click on the little arrow. We know it's stage 3B, so it says stage 1 through stage 4 is I-12.9. I'm going to click on that again and pull this up and see what it says. Hypertensive chronic kidney disease. Use additional codes, so we're going to keep that in mind, and we're going to pick up this Z87.891 because they were a former smoker. And so that is our first code we are going to assign is I-12.9. Now it also says use additional code to identify the stage of chronic kidney disease. I know they have chronic kidney disease, so let's just click on this little hyperlink and look right there. It says chronic kidney disease stage 3B and 18.32. Let's see if there are any coding conventions or instructions here. And none that we need to consider at this point. So our first two codes are going to be I-12.9 and N18.32. Now we're going to look for our diabetes diagnosis. And let's just go back here. I'm just going to click on the whole thing there. All right, now we're going to type in diabetes. Again, there's a possible causal relationship with, look at all of these different complications. This one says chronic kidney disease. So let's pull this up, E11.22. Type 2 diabetes with a related kidney problem, and this is the code we're going to choose for the diabetes. And right down here it says use additional code to identify the stage of chronic kidney disease. So how we're going to actually code this is we're going to assign the code for hypertension first, followed by the diabetes code, followed by the chronic kidney disease. Okay, I'm going to share my screen with you for one more term, which is the National Institutes of Health Stroke Scale score. So what I did is I went to Encoder Pro, I typed in the NIHSS, hit enter, and it pulled this up. So I'm going to click on the hyperlink here, and all I have to do is scroll down and find out. Our documentation said they had a score of 3. So it's going to be R29.703 is the code that we're going to assign that was documented in the patient's encounter. Okay, as you can see, I have highlighted all of the possible codes that I can abstract from this note. So I have the stroke, of course, the acute ischemic stroke, which was caused from a stenosis of the left middle cerebral artery. Hypertension, hyperlipidemia, chronic kidney disease, stage 3B, diabetes type 2. There is a stroke score of 3. There's a history of falling. They also have a pacemaker implant. They have a family history of stroke. And they are also a former smoker. So here are the final diagnosis codes that I have assigned to this patient encounter. In an earlier slide, we talked about the different arteries of the brain where a stroke can occur. We just reviewed a patient note where the stroke occurred in the middle cerebral artery, which is one of the main cerebral arteries that directly supply blood to the brain. And again, those are the anterior cerebral arteries, also known as ACA, the middle cerebral arteries, MCA, and the posterior cerebral arteries, PCA. These arteries branch from the circle of Willis. which is a loop or arteries at the base of the brain that functions as a failsafe. This means that if there is an interruption of blood flow from either the internal carotid arteries or the vertebral arteries due to a stroke or a ruptured aneurysm, the unaffected vessel can still provide blood flow to the affected part of the brain by the circle of Willis. The vertebral arteries, the internal carotid arteries, and the basilar artery are considered as the precerebral arteries. They supply blood to the brain, but they're located outside the brain or just before reaching it. This means that blood flow travels through these arteries via the neck and the base of the skull, eventually joining the circle of Willis, where the cerebral arteries, the ACA, MCA, and PCA, continue to supply fresh, oxygen-rich blood to the rest of the brain. Now that we've covered the basics of an ischemic stroke and a non-traumatic hemorrhagic stroke, and we've also touched upon the sequelae of strokes, let's talk about another type of stroke that can occur when a blood clot blocks one of the small blood vessels deep in the brain. This is called a lacunar stroke or lacunar infarct. The term lacunar describes an infarct or other lesion that resembles a cavity or hole in brain tissue. These types of strokes are medical emergencies that are life-threatening. Blood vessels in the deep layers of the brain include such areas as the basal ganglia and the thalamus. There are certain health conditions that can cause blood clots that lead to a lacunar stroke, including hypertension, hyperlipidemia, clotting disorders, COVID-19 virus, and other infections that kill tissue on the body. So when looking up the ICD-10-CM code for a lacunar stroke, you will need to first locate the term infarct, followed by cerebral, and then either occlusion or stenosis to find the term small artery, illustrated here. If you use an ICD-10-CM codebook to look up diagnoses, make sure that you read the code descriptions when assigning codes as well. As you can see here, there is a description under code I63.81 as lacunar infarction. Let's summarize what we have discovered about common coding challenges so far. We've talked about how sometimes provider documentation can be confusing, lacking detail, or even conflicting at times, which requires the medical coder to carefully examine the note looking for documentation that supports a more specific code. These types of coding challenges can be a perfect opportunity to provide education about ICD-10-CM guidelines with the healthcare provider. Another common coding challenge that we've discussed is understanding the anatomy of the brain, the types of strokes and location, documentation requirements such as laterality, and how to apply the most specific codes that accurately describe the patient's condition. We also need to keep in mind a very important ICD-10-CM coding guideline about uncertain diagnosis. We never assign codes with terms like probable, suspected, ruled out, questionable, possible, consistent with, or other similar terms that indicate uncertainty. There are some exceptions, however, to this guideline depending on the type of patient admission. So please follow up with the ICD-10-CM guidelines if you have any questions. For the purposes of this training session, we will not assign codes for a diagnosis that indicates uncertainty. So here is the Uncertain Diagnosis Coding Guideline, which you can find in your codebook, Encoder Pro, and on CMS website. So here's an example of the types of documentation where it would be appropriate to assign the signs and symptoms of a stroke rather than the type of stroke. The last type of stroke we're going to go over is the transient ischemic attack, or TIA. According to the Merck Manual Professional Version, a transient ischemic attack is focal brain ischemia that causes sudden transient neurologic deficits and is not accompanied by permanent brain infarction or damage. Most TIAs are caused by emboli, usually from carotid or vertebral arteries. Treatment usually involves antiplatelet medications and statins. So let's take a look at how to code a transient ischemic attack. As you can see here, the patient presented with garbled speech and a facial droop that lasted only a few minutes and then resolved. The provider assessed the patient and diagnosed them with a TIA, transient ischemic attack. We would assign G45.9 for transient cerebral ischemic attack unspecified, as illustrated here. Okay, we have gone over several concepts related to applying the most accurate and specific ICD-10-CM codes to help master the common challenges of stroke coding. We have reviewed the anatomy of a stroke, the different types of strokes, the sequelae of strokes, and a few common coding challenges. We've also learned some anatomy of the brain, the cerebral and pre-cerebral arteries, some terminology related to strokes, and much more. So thank you so much for your time and allowing me to share this information with you. I hope that you've received a better understanding of how ICD-10-CM codes are assigned for strokes and are now more confident about applying these codes. Thank you so much, and have a great rest of your day.